Good afternoon, and welcome to the Maryland Women's Coalition for Healthcare Reform's webinar series, Leveraging Healthcare Reform, Cultural Competency and Health Literacy Strategies. I am your host, Sandy Kick, Health Policy Analyst with the Coalition. Today we are excited to present this webinar, the first in a four-part series on cultural competency and health literacy, and the importance of both in our healthcare reform implementation efforts. Today, we will present the big picture. First, we will hear from our speakers and then host a question and answer session before wrapping up today's webinar. Please note, we have muted all phones during the presentation portion of the webinar, but will provide you with instructions for asking questions when we get to the Q&A portion of the webinar. Now I'd like to introduce Lenny Preston, Chair of the Coalition, who will be our moderator today. Lenny?
Thank you very much, Sandy, and thanks to everybody who joined the webinar today. We hope everything's going to go smoothly here. Before we get into the presentation, so I want to tell you just briefly about the Coalition, and particularly for those of you who are unfamiliar with with what we do. Forgive me for just a moment. So we're a nonpartisan alliance of individuals and 91 statewide organizations that are all dedicated to the same purpose of ensuring that all Marylanders have the health care they need and deserve. We're grateful to our national partners, Raising Women's Voices, the National Women's Law Center, and the Open Society, we're particularly grateful to them for they've made this webinar possible today. And we achieve our mission, much as many of those on this call do, I'm sure, through education, such as the program today, reaching out and engaging every possible ally in reform efforts, and looking at both policy and legislation, and then advocating and taking action. So our objectives for today include, defining the terms of cultural competency and health literacy, and looking at the relationship between the two, and also looking at how those can be measured within an organization or for individuals. And then looking at how those are related to some of the federal policy initiatives and how they intersect with state reform. And we'll also provide you with resources that you can use. And one of our speakers will look very specifically at Maryland and the relevant provisions and policies related to cultural competency and health literacy, and how those impact healthcare access, quality, and cost, and ultimately how they impact health equity, which is one of the Coalition's primary objectives. We'll talk about ongoing challenges and how we can address those with new strategies. So let me now welcome our speakers, and before I do that, let me remind everybody that we're going to wait until the end of both presentations before we actually get to the question and answer period. So we're very fortunate today to have two leaders in Maryland talking about this subject, and I'm going to start by introducing Maria Rosa Watson, who we're really grateful she's out in Alabama at the moment. So she's a licensed dentist in the District of Columbia and currently holds the position of epidemiologist and research director of the Primary Care Coalition of Montgomery County here in Maryland. She received her education in both Peru and the United States and currently is the co-principal investigator of Improving Health Services for Low-Income Latinos in Primary Care, which is funded by the National Institute of Mental Health. She leads community-based collaborative projects with investigators at Georgetown University, including a formal community campus partnership for health, and she served as an evaluator to a county-wide collaborative emergency department diversion program to connect patients into primary care and to a childhood obesity prevention and quality improvement program, and much more than I can say here. So we'll be posting her bio as well as Dr. Herrera's on the website with other materials, and I'll tell you about that at the end. But for now, I'm going to turn this over to Maria Rosa.
Hello, everybody. I have the control of the slides now. Okay, my name is Maria Rosa Watson. Thank you, Lenny, for the great introduction. I'm delighted to be here with you, and I'm charged with giving you perspective, a little bit of the background information on the main concepts, and I think I've learned very useful things that I can share with you. So first, let's talk a little bit about the definition of health literacy. This came out in an Institute of Medicine report in 2004, and this is a health literacy started from like a silent epidemic to something that now is, relevant for policy and quality, and that's why it's so important. So the definition of health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Low health literacy can negatively affect treatment outcomes and also the safety of healthcare delivery. There's studies that have shown that patients with low health literacy have higher risk of hospitalization, higher likelihood of making errors with their medications. Patients are more ill because they have problems with self-care management, so they present more ill when they seek care. They have longer hospital stays, and also they have a lower likelihood of complying with the needed treatment. And they also tend to utilize extensive services. So instead of going to primary care, they end up going more to the emergency room. So why is important health literacy? Because it affects many areas in which a patient needs to engage with their healthcare system. It doesn't let them navigate the healthcare, fill complex forms, consent forms to try to decide, which treatment is better for them. It doesn't allow them to locate the providers and services that they need. It doesn't allow them to share personal information in an accurate way, because if they cannot express or articulate their condition or their symptoms, the provider won't be able to give them appropriate care. It affects the engagement, as I said, in self-care and chronic self-care disease management. And of course, it also affects more complex, like numeracy skills, like mathematical concepts, probability, risk, calculating dosages, interpreting test results, and also being able to choose between health plans or comparing prescription drugs because they need to calculate the premiums, copays, and deductibles. And also, it's really important that the patients be able to discriminate between useful and accurate information and information that may not be accurate. So it affects also that. Oops, sorry, I went back one. Okay, so there's people, oops, sorry. I don't know now if it went down. Okay, bear with me for a second. Okay. Okay, we're in the right. It keeps going. I don't know what happened, everybody. I'm sorry. So this problem is health literacy. It's not just a problem for the public. Sometimes the healthcare professionals, like the doctors, the nurses, public health workers, the dentists, like me, can have poor health literacy skills, such a reduced ability to clearly explain health issues to patients and the public. And actually, Marilyn, as we will hear from Dr. Herrera, a very exciting toolkit has been put out to help healthcare professionals to learn how to have better health literacy skills. And in terms of the population, it affects all segments of the population. However, it is disproportionate in certain demographic groups, like the elderly, ethnic minorities, persons with low literacy, and recent immigrants. And, you have to bear in mind that, for example, there's a cognitive decline in older adults. There's people with learning disabilities, lots of people with lack of educational opportunity, so they have, high school education or lower. And even if they have a high school education, usually their reading ability is a few grades less than their last year of education completed. And, some people say health literacy equals basic literacy skills plus knowledge of health topics. However, health information is usually received in very stressful situations. So even a very literate person may not be skilled in a health environment. So, and they can be overwhelmed by the information they're being given. So it's really important that the providers be very cognizant of this problem. And also because some people may not have the background knowledge about, even if they received education about health issues when they were younger, things in the medical science changes rapidly. So there's new terms and new explanations that they may not know. So health literacy, when they look at literacy, not even health, but just literacy, looking at the National Assessment of Adult Literacy, only about 12% of the U.S. population is considered to be proficient in literacy. So why it's important to identify it? So once we identify what are the patients that need, more careful hand-holding and explanations, then we can limit our information to be short and clear, make sure that we don't use medical jargon, use of illustrations for important concepts, and make sure that the patients confirm the information that they received. And it's really important that whenever we use materials, there's a lot of materials that are not very useful because if they are not simple with a well-arranged layout, with very pertinent and simple illustrations and easy to follow formats, then most of the population cannot follow them. And actually, for the elderly, about 80% of people have difficulty using documents such as forms and charts. So we have to keep that in mind. So how can we identify low health literacy? I'm not going to focus in this presentation in all the indexes and tools that are right now out there, and there's a lot of tools being used in research. However, as a person who something that has always been an issue that is very relevant, what tools can be used to detect easily populations with most health in a way that is easy and fast in a clinical setting. It's very valuable, and the providers are, have very little time to interact with the patients. So one of the problems in developing these tools is that because there's no a perfect comparison, like a gold standard, that all tools are still being tested. And so there's no perfect health literacy measure out there that can be administered on real-life settings without investing too much in our provider time. However, there's a couple of tools that have 3 questions. And recently, a review of the literature in JAMA looked at these different tools, and they found out that the simple question, how confident are you in filling out medical forms by yourself, effectively helps identify, especially people with very low levels of literacy, which are the ones that you want to focus on. So just even if you don't have time to administer, very cognitive, asking that would be very, very important. So one of the things that you can do to help your patients is a program called Ask Me 3. Unfortunately, the findings from the research of Ask Me 3 have mixed results. However, there's a recent study with parents of children that showed that the parents felt more knowledgeable about the issues. So Ask Me 3 is a program that promotes patients ask three questions to their providers. What is my main problem? What do I need to do? Why is it important for me to do this? And they should come out of a medical visit with at least those three questions answered. And it's emphasized that providers, like the nurses, nurse practitioners, physicians, dentists, they should be able to ask the patient, can you repeat to me or teach back to me what I just told you? So in the bottom of this page, there's a link to this tool. And as I said, the research is still out, but I think any effort for more clear information is in the long range going to show useful. Another initiative was basically an act signed by government, by President Obama in 2010, in which all the federal agencies are asked to use plain language to, in any materials that they put out. So the key elements of plain language include organization of the information so that the most important points come first, breaking complex information into understandable chunks, using simple language and defining technical terms, and using the active voice. And any language that you're using with your materials or, even your health history or any forms that you're using in your practice or with your community, it is critical to know your audience. And I'm going to give I was doing a research study with researchers from 3 different Latin American countries, and we were working with a Central American population in Washington, D.C., and there were 6 different words in Spanish to identify the same thing. So it's really important that you know your audience and also to have members of your population test your materials before, during, and after they're developed, as, jargon and slang may change. So whenever you talk about health literacy, I just want to bring to, the audience that it is a complex relationship, and you always have to consider the social determinants of health. If you have low social economical status, that will impact health status, and that will impact your income level, your occupation, where you live, where you work, if you work in a hazardous condition place, and all these also affect your access to care. And I think the most important thing with working with underserved and diverse communities is to always think that, they're putting off, this population is putting off other fires, and your priorities may not be their priorities. So you really need to talk to them and make sure that they're getting the message that you want. Years, a brief definition of cultural competency and the relationship between health literacy and cultural competency. Dr. Herrera is going to talk a little bit more about efforts in place of cultural competency. I think the main thing that I want to say here is that culture and health literacy and language, communication, they're very tightly linked together, and I think that culture cannot be addressed without thinking of, communication and language skills and language preferences. I'm not going to read the slide because you have it there and you can read it, but cultural competency is considered a key element in closing the disparity gap. And about health concerns without cultural differences hindering the conversation but enhancing it and understanding where the patient comes from. And only considering cultural competency can healthcare services be respectful and responsive to the health beliefs and practices and the linguistic needs of diverse patients. I wanted to talk a little bit. I'm having the same problem. I'm sorry. I'm going to go page up 3 times. Can you help me up? One more. One down, please. Okay. I wanted to talk a little bit about the community. And I think, people with communities or with populations from underserved backgrounds really
Maria Rosa, you're fading in and out a little bit.
Okay, so I'm going to try to speak closer to the mic. Is this better?
Thank you.
Okay, thank you. So it's really important to engage the patient populations in helping you design the programs for their own care and helping you come up with what are the things that are going to work for them. What works for you or for me may not work for them. You have to provide health promotion in their community settings in places that are easy to access, and also as a way to establish relationships with community members and to be able to outreach them and connect with others in the community. It's important to promote preventive services using the voice of their peers and of trusted community informants, because there's going to be, at the beginning, a little bit of lack of trust. You need to use patient navigation and community outlets for information dissemination, which I think is going to be the theme of the next webinar. And also, in establishing trust, you have to be personable, sincere, and most of anything, I think you need to be consistent with your population so they know you are there to help. And it's important to develop strong relationships with community partners for referral and to secure continuity of care and health improvement. Next slide. I think I lost my privilege of doing my own slides. I think this is my last one slide. And I just wanted to point, this comes from 15 focus groups with about 100 people of very diverse background, included almost, that you can see of Latinos, continental Africans, African Americans, Asians, African Americans. And I just wanted to point out with this slide that if you look at the recommendation, it also aligns very well with what I did for my recommendation working on the community. People out there want providers to increase language appropriateness, increase their cultural competency, be able to work with them in outreach initiatives. So it's really important to know that community members want to work with us. So please seek them out and work with them. Next slide. So this is another study we did. It was to validate health literacy issues with Latinos. It was a sample of mostly Latinos with 40% from El Salvador, and 55% were 5 years or less in the U.S. 60% had less than high school. And it's in Spanish, but I just wanted to leave you with these words. So, people in the community, what they had to say is they don't explain to you very well what is what they're going to give you in terms of medicines or treatment, and what's what they are going to do and how much it's going to cost. The doctor never tells you that. Another patient said there's lack of information. Sometimes we need more information. It's cheaper to travel to another country and work and earn money to go and be able to pay for medical care over there. It's cheaper. And then somebody said, to go to a doctor, you have to fill so many papers, so many pieces of paper. And then you find out your insurance is not going to pay. And then you think, what's happening? So many papers that you have to fill, and then nobody explains you anything. So I just wanted to bring so
thank you so much, Maria Rosa, for that perspective. And now we'll move on to the next presentation and then come back to Maria Rosa with questions at the end. So let me introduce Dr. Laura Herrera, Deputy Secretary for Public Health at Maryland's Department of Health and Mental Hygiene, where she oversees local public health, prevention, health promotion, health systems, infrastructure, vital statistics, laboratories, administration, and the department's offices of preparedness and response, and the Office of the Chief Medical Examiner, a position she held up until several months ago. So if that didn't exhaust you, you can think about what she did before that, which was as medical officer in the United States Army Reserve and was deployed domestically to care for active duty soldiers, and also spent a time in Iraq, returning from there to serve as the National Director of Women's Health and then acting Deputy of Chief Patient Services at the Veterans Health Administration. So we're very pleased to have Dr. Herrera join us today, and I will turn it over to you.
Thank you, Lenny. Can you hear me okay?
Yes, it's terrific. Thanks.
Great. So I'm pleased to follow Dr. Maria Rosa and speak to you today about cultural competency and health literacy. Today I'm going to focus from the health professional and health organization side and then go over some of the national and state policies that provide guidance in this area. So what are health literacy competencies for organizations and health professionals? And health literacy, as Maria said earlier in her presentation, healthcare professionals, despite all their knowledge to become doctors, nurses, and public health workers, can also have poor health literacy and really struggle with clearly explaining health issues to patients and the public. And so how do we balance health literacy not just on the patient and consumer experience, but also on the healthcare organization and providers? And we know that healthcare or effective communication skills of healthcare providers are crucial in providing patients and consumers with information about their care in plain language that they can understand. And there are countless examples in the literature and the popular press about patient safety being compromised due to poor communication skills. And how can we at every encounter ensure that all patients at risk for not understanding their health condition can get the information that they need to manage their health and manage their health condition, kind of like health literacy universal precaution. So there are 10 attributes that are defined by in healthcare organizations that make it easier for people to navigate and understand and use the information and services. I won't go through all of them, and they're all on the slides for reference, but I did want to go to a few of them. So one, has the leadership made health literacy integral to its mission, structure, and operations? If it's not part of the leadership priorities, it's going to be very difficult to integrate health literacy into planning, evaluation, measures, patient safety, and quality improvement. It really needs to be part of the culture of an organization and make it a priority. And once that's part of the culture, it then prepares the workforce to be health literate and then monitor that progress through different kind of quality improvement initiatives, maybe involving the Plan, Do, Study, Act cycle. But we want to make sure that when it's done, that you want to include the population that you're serving and get impact or information from them on the design, implementation, and evaluation of the type of health information and the services you want to provide. You want to meet the needs of populations with a wide range of health literacy skills. So just because you speak Spanish, is it enough to have a Spanish interpreter or provide written materials in Spanish? What if that person who is a Spanish-speaking only individual cannot read or write in Spanish? Providing them a brochure in Spanish is not going to help that individual. We want to provide easy access to health information and services and help with navigating the system. As many of you know, the healthcare system is very complex even for those that really understand the system, and so having the cultural competency or health literacy as a barrier can make it that much more difficult. And we want to certainly address health literacy in high-risk situations, especially around care transitions and communications about medicines. So as the patient who's getting admitted gets discharged, what's needed for that individual around transition planning or around any medications that have been added or changed. So why is an integrated approach to cultural competency and health literacy important? In theory, we know that both health literacy and cultural competency have an impact on the patient care experience and overall quality of care. And as we think about the triple aim of improved health care, improved quality at lower cost, this is going to be a key part of that success. We want to improve interpersonal interactions and rapport between patients and consumers and their providers. We want to, and we know that by having these improved interpersonal interactions and rapport, we'll get a greater level of trust in the provider and the healthcare system that could lead to improved adherence. We want effective use of interpreter and translation services when needed. We know that there's a growing population with limited English proficiency in the state of Maryland, and how are we going to address some of those barriers as they start to access services, either because they are now eligible for Medicaid under the Medicaid expansion or through another payer as part of the exchange. In one jurisdiction in Harford County, they're seeing an increased number of limited English proficiency patients. So they're actually putting together a QI initiative around improving communications for those patients. And they're starting to monitor the number of times that translation services are offered and the time to getting translation services. Then we'll be looking to outcomes to see, did those physician communication skills positively correlate with patient adherence or other improved health outcomes. So there's lots of national guidance and state guidance, and on this slide is a listing of all the federal initiatives, not all, but a good number of the federal initiatives, specifically the 2010 Patient Protection and Affordable Care Act, some of you may know as Obamacare or ACA, Healthy People 2020, the Class Standards Enhancement Initiative, the HHS, Health and Human Services National Action Plan to Improve Health Literacy, and the HHS National Partnership for Action's National Stakeholder Strategy for Achieving Health Equity. And I'll have resources for all these different federal initiatives at the end of the presentation. There are also other national developments from Joint Commission to NCQA and NQF around provider and hospital-based services. But I'll spend a little time going over the different federal initiatives and what they say about cultural competency and health literacy. So the first one, the big one, 2010 Patient Protection and Affordable Care Act, which references cultural competency and health literacy throughout the law, 16 times for cultural competency and 7 times for health literacy. Specifically, Section 5307 addresses the issue, and it states that cultural competency, prevention, and public health in individuals with disability grants will be awarded. And the purpose is for the development, evaluation, and dissemination of research, demonstration projects, model training curricula for cultural competency, prevention, public health proficiency, reducing health disparities, and aptitude for working with individuals with disabilities. Now that's a lot to say, but basically that the Health and Human Services Secretary will evaluate the adoption and implementation of the different training curricula, and the goal is to facilitate the inclusion of competency measures in quality measurement systems as appropriate. So as these, or as healthcare delivery reform is enacted in different states and quality measurement systems are being developed, where are the opportunities to include competency measures around cultural competency as well as health literacy? Healthy People 2020 provides a comprehensive outline of national health promotion and disease prevention goals, objectives, and progress measures with 10-year targets. It's designed to improve the health of all people in the United States and includes an emphasis on health equity and the elimination of health disparities. It has 42 topic areas that focus on improving health literacy of the population, increasing the proportion of persons who are satisfied with their health care providers' communication skills, increasing the proportion of persons whose health care providers engage with them in health care decisions, and increases the proportion of health care professional degree granting universities whose required curricula includes content on cultural competency. So it not only addresses cultural competency and health literacy for the patients, but again, as was mentioned earlier, really starts to engage health professionals and as part of their degrees, what needs to be included in the curriculum so that providers are culturally competent and able to address the issues once they're seeing patients. The class standards were first released in December 2000, and they outline the basic principles that healthcare organizations and individual healthcare providers can undertake to make healthcare services more culturally and linguistically accessible. The standards address culturally competent care, language access services, and organizational supports. And the Health and Human Services Office of Minority Health really wants to ensure that these standards are current and appropriate and that they reflect the most promising practices and experiences for providers in the field. So they're constantly being updated to reflect those new experiences and best practices that have been identified. The HHS National Action Plan to improve health literacy has 7 goals and is based on the following 2 premises. Everyone has the right to health information that helps them make informed decisions, and 2, health services should be delivered in ways that are understandable and beneficial to health, longevity, and quality of life. And these are those 7 goals. Develop and disseminate health and safety information that is accurate, accessible, and actionable. Promote changes in the healthcare system that improve health information, communication, informed decision-making, and access to health services. Incorporate accurate, standards-based, and developmentally appropriate health and science information and curricular and child care and education throughout the university level. Support and expand local efforts to provide adult education. Build partnerships, develop guidance, and change policies. Increase basic research and the development, implementation, and evaluation of practices and interventions to improve health literacy. And increase the dissemination of evidence-based health literacy practices and interventions. And that really goes back to what I mentioned about the class standards and HHS really wanting to ensure that what gets put out there is current and appropriate and evidence-based for providers out in the field. The HHS National Partnership, it's a strategy document that presents a set of 5 goals with objectives for public and private sector health equity initiatives and partnerships. And the 5 goals set forth in the strategy are awareness, increasing awareness about the significance of health disparities and their impact on the nation. Leadership, strengthen and broaden leadership for addressing health disparities at all levels. And this speaks to that culture change that I mentioned earlier. So whether that's leadership at your federally qualified health center, leadership at your academic institution, or leadership at your healthcare system or hospital system, to really understand the importance of cultural competency and health literacy. Health system and life experience, improve health and health outcomes for racial, ethnic, and underserved populations. Cultural and linguistic competency and the diversity of the health-related workforce. And lastly, data research and evaluation, improve data availability, coordination, utilization, and diffusion of research and evaluation outcomes. We're working on that internally in our own data systems, as historically race and ethnicity data have been asked in that particular order, yet we know that when ethnicity data is asked second, it's often not answered. And so now we're working with our different partners that report data to the state to change that, to more accurately capture the data that we're looking for so that that data can in turn be actionable for community providers, health professionals, and other community-based organizations. So there are several Maryland policies and initiatives underway, which include in last year with the Maryland Health Improvement and Disparities Reduction Act of 2012. Some of you may know this as the Health Enterprise Zones Bill, Cultural Competency and Health Literacy Education Bill that was passed also in 2012, Cultural and Linguistic Healthcare Provider Competency Program in 2009, and Health Disparities Institutions of Higher Education, and that was in 2008. I provided the House bill or the Senate bill numbers, so for those of you who want to read each of those respective bills in more details, you have them available. The other initiatives in the state of Maryland are listed below. I'll spend a little time going over the policies. So the Maryland Health Improvement and Disparities Reduction Act of 2012 seeks to reduce health disparities, increase access to care, and better health outcomes among underserved communities and reduce health care costs. And the idea was that if you could demonstrate cultural, linguistic, and health literacy competency by healthcare professionals in a particular area, there would be incentives to help address those cultural, linguistic, and other competency issues in those respective areas. These areas are defined as health enterprise zones, and it was a way for communities to start addressing some of the health disparities that are secondary to cultural and linguistic competency issues in an effort to improve health outcomes in those areas. It includes an implementation of a health plan evaluation system that incorporates a standard set of measures, including actions taken by health plans to track and reduce health disparities, and whether health plans provide culturally appropriate educational materials for their members. And this is all being decided now as part of the health insurance exchange, as qualified health plans look to join the exchange and provide coverage. This will be one of the things that they will be graded on. And lastly, it convened a work group of the Maryland Health Quality and Cost Council to examine appropriate standards and reimbursement mechanisms for culturally and linguistic competency. So as more organizations and healthcare providers engage in culturally and linguistic competent care and provide services that are culturally and linguistic competent, that can often take longer, but how can those providers and those institutions get reimbursed for providing that care? It will assess the feasibility and develop recommendations and criteria for standards establishing multicultural healthcare equity. And it will also recommend criteria for healthcare providers in Maryland to receiving continuing ed in multicultural healthcare. The 2008 statute of cultural competency and health literacy education requires schools of medicine, nursing, dentistry, and pharmacy to report on courses they are offering to address both culturally and linguistic competent and health literacy care. And it calls for institutions of higher education to work collaboratively with the Maryland Office of Minority Health and Health Disparities to develop courses on cultural competency, cultural sensitivity, and health literacy. The Cultural and Linguistic Healthcare Provider Competency Program of 2009 encourages healthcare professional associations in Maryland to identify or develop training programs focusing on teaching healthcare professional methods to improve their cultural and linguistic competency in communications with patients. The statute requires DHMH to develop a method through which the health occupation licensing boards will recognize the training received by healthcare professionals. So this is a follow-up to what I just mentioned in 2012, and all the boards recognize this as an ongoing issue and are working again on what those methods will look like and how do they record the training received by their healthcare providers. The Health Disparities Institution of Higher Education report was from 2008 and required universities, colleges, and higher education programs of medicine, nursing, pharmacy, and dentistry in Maryland to report to 3 General Assembly committees on their courses that address cultural competency, sensitivity, and health literacy. And what we found in 2009, from what was submitted in 2009, that there was large variations in the content and manner in which cultural competency education is offered. So in the template that was previously provided in 2009, that template for 2012 is formatted to try and start comparing apples to apples, for lack of a better description, and reduce some of the variation in the content and the way in which cultural competency is offered at these different educational programs. So that report is pending and will be available on the DHMH website once it's available. This is a list of resources that not only includes resources within the state of Maryland, but the U.S. Department of Health and Human Services, the CDC Health Literacy Training Resources. HRSA has a health literacy course, as well as the Office of Minority Health, Think Culture, Cultural Health Program. But HHS overall, any of the programs the federal programs that I mentioned that are overseen by HHS can be found at their website. And lastly, I want to end that on last Tuesday, February 16th, Maryland released a teaching guide on cultural competency and health literacy, and the goal is to improve health outcomes and reduce disparities. It is currently available at our website at www.dhmh.maryland.gov. If you click on the home page, there's an announcement that talks about the primer. It covers 6 modules that include the first module on health disparities, the second on community strategies, the third on bias and stereotyping, the fourth on effective communication skills, the fifth on use of interpreters, and the sixth on self-reflection and culture of health professions. And it's basically a learning resource, and so you can use any or one of the modules depending on the needs of your organization. And lastly, I want to thank Monica McCann, who's the Director of Workforce Diversity of the Office of Minority Health and Health Disparities. She is really the subject matter expert here at the Department of Health and Mental Hygiene and helped prepare the slides for today's discussion. And with that, I thank you all, and I'll turn it back over to Lenny. Thank you.
Thank you so much, Laura. That was terrific and a huge amount of information for everybody to absorb, but we will put that up on the website so others will have access to it. And now we have little time for some questions. So our tech guru, Zenobia, do you want to go ahead and explain that?
Yeah, thanks, Lenny. I'm now going to officially begin our Q&A session. You should hear an automated voice saying Q&A session started. If you would like to ask a question, hit *6 to unmute your phone. When prompted, press 1 to enter the question queue. When prompted, state your name, organization, and question. Lenny and our speakers will provide answers to your questions. We will now begin the Q&A session. If you have a question, you can hit *6 to unmute your phone and proceed.
Thank you, Zenobia. And while we wait for others, if I could just ask, since our next webinar is actually going to focus on Maryland's Connector program and the navigators and assisters, and you both touched on this, I'm wondering what specific strategies you might suggest that in the training and certification process for navigators and assisters the exchange might be looking at, perhaps things you're aware of now. And then also, I think, Laura, you touched on the need for a feedback loop from the connector entities to ensure that, in fact, this cultural competency, health literacy piece is part of the process. I'm just wondering what thoughts you both might have on that.
Are you asking me, Lenny?
That's fine. I was asking both of you, so go right ahead, Maria Rosa.
Okay, so I just wanted to say, that when you work with peer promoters and navigators, I think it's really important that they know, too, that it's really important to hear to everybody in the community, and that look back, making sure that, even when things are tested, that you go back and check with the community that things have not changed, and also check with them, over and over that the message that you're providing is really, having an effect on the work that they are doing.
Right. Thank you. Laura, did you have anything you wanted to add?
No, I would just say to the exchange piece and what you were saying about the navigators and the assisters, as a feedback to the health plan, I mean, the health plans will have requirements for network adequacy, and it'll be important that that processes we will develop for monitoring changes in network composition, specifically around culturally competent providers, as well as there'll be procedures in place for addressing special populations such as limited English proficiency and communication with enrollees on how they're informed about planned services and complaint procedures if some of those things aren't being met. So the assisters and the navigators will not only help patients choose the plan, but that the plans themselves will be held accountable to meet the needs of those patients that have limited English proficiency or other issues around health literacy and cultural competency. They will need to be met as part of being in a network adequacy.
Great, thank you. Zenobia, do we have any questions?
We do. We have a question. Please remember to state your name and organization when prompted.
Can I ask a question?
Yes, go right ahead.
Sally Alexander with the Mid-Anne Arundel County team. It's a very simple question. How will the plethora of wonderful information that we've just been exposed to be available to us?
Thank you. So on our website, mdhealthcarereform.org, you will see at the top an events tab, and it will be posted there, and we'll put a link, a heading on the home page to be sure to drive people there. So, and if you have any problems, the last slide up here is going to have my email address, so you can always track us down that way or through the website.
Thank you so much.
Thank you. Anybody else, Zenobia?
There's no more questions in the queue.
Okay, well, I guess we numbed them with that fabulous information. And as I just said, there'll be both a recording of today and the slides themselves will be up there, as well as a list of all of the resources that will be useful to all of you going forward. I just wanted one of the sets of resources pages that will go up in a second. There are a number of sources in the state that you can use now that include the stakeholder website for the Maryland Health Benefit Exchange, and as well as Maryland Health Connection, the new site. So be sure to go to those. Also, this was the first of a 4-part webinar series. So the next webinar will be in June. We'll be setting the date, and as suggested today, that will focus on the Connector program and addressing the areas of cultural competency and health literacy within that context. In the late summer or early fall, we will look more deeply into the issue of culturally competent providers. And then the 4th webinar in mid to late fall, we'll look at what we think of as our ultimate goal, which is a culture of health, educated consumers, and small businesses. So we hope that if you have further questions, you will feel free to contact us. All of these links will be up on the website, and you can find Dr. Watson at primarycarecoalition.org and Dr. Herrera at the Department of Health and Mental Hygiene. We thank them very much for their participation and willingness to share their expertise with all of us today. And thank, of course, all of you on the web for joining us. We encourage you to stay informed and get engaged, as we like to say, because Maryland is not going to get it right if we don't all get it right with them. So thank you very much, and we look forward to having you join us in the future. Goodbye.